I have
Yeah, you start first.
Oh, the company man wanted to speak something, no? Lupin.
No. You start first
Okay.
and hand over to me. Then,
Yeah.
Gaurav, are you listening?
Yes, ma'am.
And then I'll just say a few words and then I'll start sharing my PowerPoint. Okay. And then finish with some few words about Trichy, and then I'll talk about the topic. And then I'll hand over to Vidya again to introduce Dr. Jyotsna. Vidya, you also give the closing comments for Jyotsna. Yeah. And I'll introduce Dr. Osama after that. And also give the closing comments. Dr. Rishikesh also, I'll introduce.
Yeah, okay.
And you join me for the concluding
Q&A
remarks and the question and answer.
Yeah, sure. So shall we start now? Sir?
Yes, after 10 seconds, ma'am, you can start.
Okay. Shall I start?
Guys, are we live?
Yes, ma'am, please.
Yeah. Good evening, everybody. I think, I hope all the logged in delegates are able to hear me. I'm profoundly happy to invite the international faculty as well as the national faculty who has joined us today to share their experience and also to share their knowledge. I think I should thank Deepa first because she has made it possible to happen this evening. So congratulations, Deepa. You've gotten very, doyens in their own field and made them all come together in a same platform in our Trichy ONG society. So on behalf of the society, I welcome one and all. And first of all, Dr. Osama Shawki, as Pai said, the king of Egypt. And he's a king of hysteroscopy also. Dr. Rishikesh Pai, again, king of Mumbai and India, I should say. So the future president. Sir, I welcome you. Sir, Osama, sir, I welcome you with an e-bouquet of roses. I think you accept it. It's only an e-bouquet. I'm very sorry. If at all it's a live one, I would have given you a better welcome. And Sir Rishikesh Pai, I welcome you again with a e-bouquet of roses. Thanks for sharing your time here amidst your busy schedule. Dr. Jyotsna, she became my very good friend just when we logged in. And she happens to be a very joyful and a very happy consultant at NHS. Welcome, Jyotsna, to our webinar. We are really happy to have you. It's my honor and prestige to welcome you all, esteemed faculty, for this webinar. And I think last but not the least, I welcome all the delegates and also a warm welcome for the technical team from Lupin. Now I think you can go over to Deepa.
Thank you, Vidya. It's been a long dream for me to live this day. I have such a wonderful faculty for the Trichy Society. So first of all, my deep sense of gratitude to all the faculty, Dr. Jyotsna, Dr. Osama, and Dr. Rishikesh Pai for having consented to be with us today on this web platform. I do welcome all the delegates as well. For those of you who have been afflicted with COVID, my heart goes out to the world, to all those people who are afflicted with COVID, and to all the frontline warriors. This is a bad time for us. Definitely we need to cross this. Meantime, I think if there's anything good that COVID has done to us, it's probably this platform that it has given to us. Otherwise, I think it'll be a great difficulty to have such eminent faculty from across the globe talking to us and interacting to us on this virtual platform. As so many delegates across the world can even log in and interact with this great faculty. So, so let's think it's probably a blessing in disguise. For those of you who have no idea about where we come from, I'd just like to share a small PowerPoint about our place, Trichy. Give me a few seconds, please. My slides are visible.
Yeah.
So greetings from Trichy. We are located in the South India, in the state of Tamil Nadu. We are located about 320 kilometers from Chennai. We are called the Rockford city. Just a few words about our city. It's a temple town. It's a very famous temple town of South India with great temples and dams and beautiful churches, etc. And sometimes Trichy, as it is called as Tiruchirappalli or the Rockford city. This is a Rockford temple that was built in one rock way back in 7th century. This is a pride of Trichy. That's a vintage picture of the temple, and that's the beautiful silhouette of this temple in the evening sunset. And we're also blessed to have some beautiful monuments like some churches with Gothic architecture, and the jewel on the crown of our city is the Srirangam temple, otherwise called the Bhuloga Vaikuntham, or the abode of heaven on earth. This is in fact the world's largest functioning temple of Hinduism. Angkor Wat is the largest non-functioning temple in the world, but Srirangam is the world's largest functioning temple. So just like the Nile Delta, we live on the Kaveri Delta, and so that's about Trichy. Trichy welcomes you from the bottom of our hearts. That's Dr. Vidya and myself. Big namaste to all of you. The new cool for 2020 and 2022, I think. Ideally, we would have loved to give Dr. Osama and the entire faculty a warm welcome like this, with pomp and splendor, a lot of fireworks and garlands. Unfortunately, this is a webinar, and so we have just giving you an welcome, sir, and to all the faculty as well. And so that's it. TRIOGS welcomes you. I loved all these pictures, so they are all here with me today. It's a blessed day in the history of TRIOGS, I should say. So there goes a few words about Trichy. Let me stop sharing this. And to Dr. Osama and the other faculty, I have this for you, sir. So, yeah.
I'm coming.
Yeah, when you all come to Trichy, let's rock on the city of Rockford. So going on to the scientific session, we are going to have a great scientific session today. The talk is all about fibroids and fertility, what to do, when to do, and how to go about treating infertile patients. Many times we come across patients in our clinics with infertility, unexplained infertility. We are not sure, and when we do a scan, we see an innocent fibroid sitting there. We're really not sure whether this is a cause for infertility or whether you should be treating it. And after a few cycles, you're all the more in a dilemma. You don't know whether to remove it before ART, especially. Would this be the reason for ART failure? So lots of ifs and buts about this topic, lots of controversies. So we're in for a great session today. I think before we move on, I should thank the ICOG for giving us one ICOG point as credit for this webinar. And I should thank the Lupin India, the pharma company that has given us great technical support. Mr. Ashish Singh is here, the DGM of Lupin. I invite Mr. Ashish to just say a few words, and then we'll go on with the scientific session. Yeah.
Thank
Mr.
you, Dr.
Ashish.
Deepa. Thank you, Dr. Deepa. First of all, very good evening to all of you. My name is Ashish Kumar Singh. I'm DGM Marketing with the Lupin Phoenix Division. Phoenix is born in 2016 as a dedicated division to gynecology and women health. So on behalf of Lupin, first of all, I welcome all the international faculties of ours and the national faculties, to start with Dr. Josna Pundir from London, Dr. Osama Shauki from Egypt, and our very own Dr. Rishikesh Pai from India. And also I have a very warm welcome to all the delegates who have joined today on this very specific webinar, and very interesting webinar on this topic, which is related to fibroids and infertility. So Lupin has always been at the forefront in supporting science-based programs, whether be it related to knowledge or the skills. And this, from the inception of Lupin, we have been doing it. And going further also, this is further going to intensify only. So we are first of all very thankful for Trichy Obs and Gynec Society and Foxy to consider us as a scientific partner for this particular program. So thank you very much for showing trust in us. And with this, now I would not like to take any further time and then want to come between you and scientific fees. So would like to once again hand over the session back to Dr. Deepa. Thank you, Doctor.
Yeah, let's not keep the audience waiting. Dr. Vidya can introduce the first speaker for the day, Dr. Jyotsna, and we move on. Vidya?
Yeah, thank you, Deepa. As everybody has already said, Dr. Jyotsna Pandit is Queen of UK. After going through her profile, I learned that she's been doing a vast study and vast, her work has been very vast. So she is a subspecialist in reproductive medicine and surgery, and she's a consultant reproductive medicine and minimal access surgery, Center of Reproductive Medicine at St. Bartholomew. I'm sorry, I'm unable to. St. Bartholomew's Hospital, Barts Health Center, NHS, Trust, London. And she's a lead for menopause care and is an honorary senior lecturer, Queen Mary University, London. And she's a secretary, RCOG, India Liaison Group, and author. She's authored many books. For example, it is evidence-based algorithms in obstetrics and gynecology. She's an educational supervisor, and she's also trained many people in Britain Fertility Society. Is it right, Jyotsna?
That's right, Dr.
Yeah, and assisted conception modules and MRCOG Part 2 course RCOG. So this is about a short description about her achievements. I think, Jyotsna, you have more behind your name, and our best wishes for you to again gain more in the future and become the greatest queen of England. Thank you.
Oh dear. Thank you so much for such a kind introduction, Dr. Vidya. Both of you, Dr. Deepa and Vidya, thank you for this kind invitation for this webinar to begin with. What I'm going to do is I'm going to talk about the controversies in the fibroids. Now, as I generally say to my audience, particularly Indian audience, my role here is to bring the evidence together and to tell you or to explain to you what is the current recommendations and leave it up to you to decide how you manage these patients. So basically in next 15 minutes, I'm going to talk about fibroids and fertility, and then the operations which we do for fibroids, which is myomectomy and fertility. What are the guidelines and evidence behind it, and what's the take-home message? To be honest, this topic is, I think, most controversial in the field of fertility, and I can spend hours on it. But the reason you can spend hours on it is because there's nothing much conclusive there. So you can talk for and against for as long as you want to. I'm not going to dwell into the technicalities of it because that will be done by Dr. Shoki, and I'm not going into the details of ART or non-surgical treatment because that will be covered by Dr. Pai. So why is it so controversial? Because there are so many variables in it when you talk about fibroid and fertility. First and foremost, age of woman and the ovarian reserve. Second, what are her symptoms? Is she entirely asymptomatic? Is it non-fertility symptoms, which is dysmenorrhea and menorrhagia, or is it fertility-related symptoms? So it can present with various symptoms. And then has she got fertility-related problem, which is actually subfertility, or is it miscarriages, or is it combinations of these? And then when you come to the fibroids, it's even much more difficult because number of fibroids can be 1 to 100 or more or less, but that is a huge variable. Where are they located? Submucosal, intramural but submucosal component, or is it subserosal? And then how big is it? And most importantly, which I might not have kept it here, is Is it one? Is it two? Or is it multiple? So it's just not one, but there are too many variables here. Now, this is the new FIGO classification, and just purely based on the location, it has been classified from 0 to 7. But that is the puzzle. Since there are too many variables, in fact, it's not even a 2D puzzle, it's a 3D puzzle. And to bring these variables into one streamline is really difficult, because if you want to conduct a study, it's almost impossible because of the fact that how you're going to randomize them, how you're going to choose them, how you're going to select them. And that's why the management is equally controversial. So there are three main important questions I generally believe is there to consider. One is, does the presence of fibroid affect reproductive outcome? So is it a problem to begin with? And if it is a problem, if you remove the problem by myomectomy, does it improve the reproductive outcome? And then if you have a procedure to improve, what type of procedure do you want to do? Myomectomy can be done laparoscopically, and open surgery can be done, or a transcervical resection of fibroids. So which one is better compared to the other? The problem here is we don't have answers to most of this. So first and foremost, question one, does presence of fibroid affect your reproductive outcomes? Now, we all know that most women affected with fibroids are fertile. So just presence of fibroid doesn't cause infertility per se. Even though this association with infertility is not supported by clear biological rationale, several hypotheses have been suggested to explain how fibroid may cause infertility or repeated miscarriages. So there is, if it is a isthmic fibroid, or fibroid twisting the tube, or is it submucosal fibroid acting as a foreign body? So these are all hypotheses which has been put forward. But we all very, very, very well known, aware of the fact that lots of women get pregnant in spite of presence of fibroids, right? So when you look for the guidelines, this is the pyramid, which I'm sure all of you are aware of it. So if I have something in that form of guidelines, I'll stick to it. If not, I'll go towards a second one, which will be systematic reviews. And then I'll show you what is the problem here. The problem is there's no randomized control trials, but that's the bottom line. So ASRM has released this 2017 recommendations. When you read recommendations, one most important thing which you must keep in mind is the grade of evidence. This is the most crucial bit, because if grade A in this document is there's a good evidence, generally based on randomized trials or meta-analysis, there is a fair evidence which is generally based on observational data, and C is there is insufficient evidence, therefore they put expert comment on it. So there is insufficient evidence to conclude that fibroids reduce the likelihood of achieving pregnancy with or without fertility treatment. I'm sure everybody is happy with that. There is insufficient evidence to determine that a specific fibroid size, number, or location, excluding submucosal or intramucosal fibroid impacting the endometrial cavity, is associated with a reduced likelihood of achieving pregnancy or increasing risk of miscarriage. So it's very important to kind of admit that there isn't much evidence there. The Canadian guidelines, which are one of the fantastic guidelines you could come across, these are from 2015. And this is management of fibroids in women with otherwise unexplained infertility. And of course, they say that subserosal fibroid do not appear to impact on fertility, so please do not touch it. Just forget about it. The effect of intramural fibroid on fertility remains unclear. If intramural fibroids do have an impact on fertility, it appears to be small and to be even less significant when the endometrium is not involved. So moving on to question 2 and 3. So first and foremost, we don't even know whether, well, we think that presence of fibroid doesn't really cause infertility based on our literature. and even experience. So does myomectomy improve reproductive outcome? And which type of myomectomy is better? For this one, I'm going to move to systematic reviews because there are a couple of them available in the literature. And then I'll come back to the guidelines, which are more or less based on these data. So this is Cochrane database from November 2012, which looked at the surgical treatment of fibroids for subfertility. Now they included all trials, but the problem with Cochrane review, or the advantage with Cochrane review, is it has to include only RCTs. So of course, it's a population was infertile women with uterine fibroids. The intervention was to do myomectomy without myomectomy. And then when you do myomectomy, which type of myomectomy? And you're looking for fertility outcomes, and you're including only randomized controlled trials, okay? So the results from their data is that there's one RCT in the whole literature addressing this question. And they showed no evidence for a significant effect on either clinical pregnancy rate or miscarriage rate for any kind of fibroids. There were 2 randomized control trials which compared open versus laparoscopic surgery, and they found no difference between the pregnancy rates, miscarriage rate, preterm labor, or cesarean section rate. All right. So then from this, they concluded that there is barely any data to evaluate the role of myomectomy to improve fertility. And there's no difference between laparoscopic and open approach. Let's move to the transcervical resection of fibroid, which is hysteroscopic myomectomy. This is a systematic review which looked at all uterine cavity abnormalities, including polyps, septum, and fibroids. So I have picked up the fibroids bit. So they looked at the RCTs comparing between operative hysteroscopy versus no operative hysteroscopy. So you got 100 patients, 50 you operate, and 50 you do not operate, and you see. And they looked for the unexplained infertility outcomes and prior to assisted reproductive technology outcomes. And of course, they looked for live birth rate. For submucosal fibroid, there's one RCT. So this is the whole problem. So the previous Cochrane review also had only this RCT, and this also has only one RCT, 94 women, and submucosal fibroids, of course, with or without intramural fibroids, otherwise unexplained subfertility. And this study is from 2006, actually. And it's a very low quality evidence purely because of numbers, to be honest. And then it was uncertain whether hysteroscopic myomectomy improves the clinical pregnancy rate or miscarriage compared to expected management. So what I'm trying to say is, even for submucosal fibroid, even for TCRF, there's not barely any data there. And there's of course no data in live birth rate or complication rate. And prior to assisted conception, there are no studies. That is the problem. Okay. So this, I'm going to move on to observational data, and I'm going to move on to intramural fibroids. So this is a very well-known paper actually from Human Reproduction. So intramural fibroid, it's not distorting the uterine cavity, and does it make any difference? This is observational studies, quite a large numbers, and there was a significant decrease in birth rates with women who have no cavity distorting intramural fibroid compared to those without fibroids following IVF treatment. However, the most important thing here to understand is there is absolutely no data to tell us what happens if you remove these fibroids. Does it improve the pregnancy? We don't know. This is a paper from 2017, which looked at the fibroids that do not distort the uterine cavity, and they looked at the IVF. It's an observational data, retrospective data, matched control trial from a single center. And they looked at presence of non-cavity distorting fibroids, and they reported that it appears to negatively affect clinical pregnancy rate and live birth rate in patients undergoing IVF cycle. We're not talking about general unexplained infertility, subfertile people. This is prior to IVF cycles. And this is a question which keeps coming and popping up. And this is the only paper which has kind of tried to answer it. And even though it is observational, they said the deleterious effect of fibroids on live birth was significant in women with 2 or more fibroids and in women with 3 centimeter or bigger fibroids. But otherwise, there's nothing else in the literature. So when you talk about evidence, Research to date has been limited to retrospective cohort or case control studies, and naturally that is fraught with their intrinsic biases, confounding factors, and clinical heterogeneity. So I'm going to move on to these guidelines about the management to summarize, because I cannot dwell too much into the evidence, to be very honest, because it gets quite complicated. The management of uterine fibroids in women with otherwise unexplained infertility, SOGC guidelines from 2015. So their recommendations are: preoperative assessment of submucosal fibroid is essential to the decision for the best approach for treatment. I'm sure all of you agree with it. Adequately evaluate and classify fibroids, particularly those impinging on endometrial cavity, using scan, hysteroscopy, HSG, or MRI. Evaluate the fibroid size, location, degree of invasion of the cavity, and its thickness of residual myometrium to the serosa. This is one of the very crucial points to understand, which I'm sure Dr. Shawki will address, because that is where your risk of uterine perforation comes in. In women with otherwise unexplained infertility, remove submucosal fibroid to improve pregnancy rates. Manage submucosal fibroids hysteroscopically. The fibroid size should be less than 5 centimeters. Repeat procedures are often necessary for larger fibroids. I'm not going to go into the technical details of it. There is little evidence on the use of Foley's catheter, estrogen, or IUDs for the prevention of intrauterine adhesions following hysteroscopic myomectomy. There's a fair evidence to recommend against myomectomy in women with intramural fibroids and otherwise unexplained infertility, regardless of their size. If the patient has no other options, the benefits of myomectomy should be weighed against the risks, and management of intramural fibroids should be individualized. If fibroids are removed abdominally, efforts should be made to use an anterior uterine incision to minimize the formation of postoperative adhesions. Pregnancy rates by laparoscopic and mini laparotomy approaches are similar, but the laparoscopic approach is associated with a quicker recovery, less postoperative pain, and less febrile morbidity. I'm sure all of you agree with me with that. But patient selection is crucial. It should be individualized based on number, size, and location of the fibroid, and of course on the skills of the surgeon. Moving on to ASRM guidelines, this is also to improve fertility and to reduce miscarriage rate in asymptomatic patients. So ASRM very, very clearly acknowledges that these are the unanswered questions. So what is the impact of leiomyoma on fecundability? Does the degree of cavity distortion impact the benefit of myomectomy? Because it's, again, when you see in real life, you see patients who have mainly intramural fibroid and slightly distorting the cavity. What are you going to do with these? And if the size is even smaller, even 2 centimeters, if it's too big, you possibly go towards myomectomy. But if it is a small fibroid, but it is causing a cavity distortion, then what are you going to do? We don't know. What is the true impact of intramural fibroids with no submucosal components on reproductive outcomes? We do not know. What is the value of myomectomy on ART outcomes? We do not know. So to summarize, ASRM says that there's a fair evidence. So please remember, even for hysteroscopic myomectomy, it is still fair evidence because there's no studies for submucosal fibroids to improve clinical pregnancy rate if you do transcervical resection. There is insufficient evidence that hysteroscopic myomectomy reduces the likelihood of miscarriages, even with submucosal fibroids. There is insufficient evidence that myomectomy reduces miscarriage rate, even if laparoscopic or open. In women with cavity distorting fibroid, intramural with or without components of submucosal, myomectomy may be considered to improve pregnancy rate. Myomectomy is generally not advisable to improve pregnancy outcome in asymptomatic infertile women with non-cavity distorting fibroids. However, myomectomy may be reasonable in some circumstances, particularly if there is a severe distortion of pelvic architecture and you cannot reach to the ovaries because there's a fibroid between vaginal skin and the ovary. We sometimes actually end up doing transabdominal egg collection in these people, particularly if they have previous surgeries. But that might be a place where you want to think about removing the fibroids. I'm going to finish my talk with this editorial comment by Wonderween in BJOG, which is a very interesting quote, I thought. So we as gynecologists have been and still are practicing myomectomies in women of reproductive age without the underpinning evidence and without even trying to provide the evidence. The negative impact of uterine fibroids on pregnancy rates after IVF does not de facto suggest that surgical management in the form of open or laparoscopic myomectomy could alleviate this effect, and that to date, RCTs on surgical management of such fibroids are lacking. So the reason for this is then to a certain extent attributed to short and long-term complications after surgery. This means that myomectomy is offered to these patients in routine care, but not as part of RCTs or any study out of fear of complications? Does that actually make any sense? Or more importantly, is it ethical? That's all. Thank you.
Thank you, Jyotsna. It was a wonderful, neat presentation of hitting the nail on the head, saying, when you look at myoma, please stop and look at these guidelines. So all these guidelines are, I think, very late for us to realize, because we have done a lot of myomectomies already, and whether they have improved fertility or not, we don't know. So this is a very good explanation which you gave, so that the take-home message for the audience is very clear that once you see a fibroid, you have to look into all the guidelines and see whether they are subfertile or whether this fibroid is really causing infertility in them, or even if so, whether laparoscopy or hysteroscopy is needed. Your guidance says so many facts here. You have disclosed so many facts from all these guidelines. Thank you so much for awakening us regarding myomectomy, Jyotsna. Thank you.
Having said that, hysteroscopic myomectomy is probably going to give the best results. It's right that we have the next speaker with us, who is a doyen of hysteroscopic surgery, our friendly neighbor from Egypt. He is no new icon to India. He has attended as faculty in 11 AICOGs, and he has addressed around 80,000 gynecologists. Not only addressed, he has trained hundreds of gynecologists in hysteroscopy. Rewind a few years, I was in Cairo just sightseeing, but I missed this phoenix of a man. So good to have you here today, sir. To talk about Dr. Osama, I think the world knows what he is and what he is capable of doing. He's a magician behind the magic wand. That's a hysteroscope, what we do. And to talk about his personality, he's such a motivator. He's not only a skilled surgeon, he's also a great motivator and an inspirational speaker. I'm sure people love him for what he is. He has coined a separate name called Osamivations. I came across this, sir. I would like you to explain that as well. I never followed that. So when I was just scrolling some pages on his Facebook timeline, I just saw that profile read simple ... human. Well, I would like to fill in that by simple human, superhuman. So that's what he is. Actually, his presentations are lovely, a definite treat to the eyes. And wherever he is, he sends so much of positive energy around, and people love him for that. And from AICOG and from our Foxians, sir, to be very honest, when I shared this flyer, many of them sent their greetings to you from Foxy. Unfortunately, we can't have many people here on the platform. So welcome to Dr. Osama. Very nice to have you. He's going to talk to us on hysteroscopic myoma resection, the challenges, beat and win the fear. Over to Dr. Osama.
Deepa, you immersed me with emotions that I cannot speak now. And after all this popularity, I think I can run for Foxy election against Rishikesh Pai next time. Okay.
Good motivation now.
Okay, so
sir,
let me.
careful.
Okay. Is my screen seen?
Yeah, seen, sir.
Yes.
It is. I think you should make it in a larger
So
size.
before I start my screen, definitely it's whatever the number of participants in this platform, but I'm really very, very happy to join my friends, okay? Maybe you don't know that the first person or the second person I know in India in my life was Rishikesh Pai. After the Mahatma Gandhi, definitely, okay? So he was very young with the same color of hair. I think he put color on his hair because it's the same colors for more than 25 years, all right? And I lost my hair. So
You're jealous, sir.
I know her name, but maybe first time I see her face. Vidya is also very known to me. Deepa is my friend. So I will live a friendly attitude with you, not telling science from the books. Anybody can open the book. It's available for everybody. Just Google search and you'll get all the information. So you don't need to invite me to waste your time to tell you what the book is saying. I will tell you what I think, which could be crazy, which could be logic. And then you think the books tell, the guidelines say this, Osama is saying this. So either the guidelines need a guideline or there's something different. So, are you ready?
Yeah.
Okay, let's. So, once again, very sincere welcome to all my friends from south of India, from north of India, from every part of India. And you know, Deepa, I know that you live in the south.
Yeah.
So once upon a time, I was invited to Trichy. You know where is Trichy?
Kerala.
It's in
Okay.
Kerala.
I wanted to say a welcome to them. So I said, I love all India, but India on the map looks like a cup of tea. And the sugar is in the most down in the south. So the south is the most sweet. So the people applauded and laughed and they said, Osama, tomorrow you are visiting New Delhi. You are visiting Dr. Alka Kriplani. What you will say? I felt that I have to find some excuse for Alka and from the Malhotra, Jaideep Malhotra as well. So I said, okay, if the south is like the cup of tea and the sugar on the south down, so sometimes I see India like a cup of cappuccino and the cream is on the top, on the north, okay? So I visited each and every corner. I'm proud that I'm not like a tourist who visited only the big metropolitan cities. I visited the little villages. Sometimes there is no electricity. We were working by generators and the only transportation was auto rickshaw for me, you know. I completed 168 training program, more than 3,000 challenging operations. And I gave a hands-on training for more than 5,000 gynecologists. And I was privileged to attend more than 8 AISOGs, and each time there is 10,000 gynecologists. So I did shake hand to 80,000 doctors in Greater India. So I'm the most lucky man in the world, okay? So are you ready to hear the story of fibroid?
Yes.
Okay, let me entertain you by some funny things about fibroid. The first surgery to remove fibroid was in 1809 in the United States. And the surgeon was Ephraim Magdul. And you know that the patient was the cousin of the President of the United States. The patient was the cousin of Abraham Lincoln. And they didn't know that she has a fibroid. They thought that she's pregnant because it was a huge belly. So they opened the belly and they found a mass. They didn't know what this, so they removed it. This was the first myomectomy in history. You will be smiling when you hear this from me now, that in the year 1845, two brothers, Washington and John Attlee, they winning the annual award of the American Medical Association. You know why? Because of their success, great success, performing 11 myomectomies with only 50% mortality rate. So, but the real modern history of myomectomy was to that great man, Victor Bonney. I think that my generation, Rishikesh Pai, Dr. Vidya, our generation, we learn from the book of this man, Victor Bonney. They can exist anywhere. Call it subserosa, intramural, whatever it is. But we all know that they are mostly innocent until they start to migrate toward the cavity. When you come near the cavity, the problem starts to happen. And this is the latest classification by the FIGO. And I thought this slide in the presentation of Rishikesh, but allow me to repeat it, please. So this is the FIGO classification according to the location of the fibroid. So type 0, when the whole myoma dangling inside the uterine cavity attached by a narrow pedicle stop. Type 1, more than 50% bulging into the cavity and small part intramural. But type 2, most of the myoma deep intramural with very less inside the cavity. Type 3, type 4, both of them intramural. But type 3, intramural touching endometrium. Type 4, intramural touching the serosa. And when it starts to migrate outside the serosa with less than 50% bulges, type 5, more bulge subserosal, type 6, and the type 7 is equivalent to type 0, but is pedunculated subserous. Which one suitable for hysteroscopy? You know that science is dynamic, it is not static. What was indicated in the past could be changed in the modern time, in the present and the future. So people thought that there should be an appreciable bulge into the cavity. And this is true, because the more deep intramural part is more difficult, but also more skills, you can approach more difficult cases. So there is no absolute. I will show you at the last case in my presentation, type 5 myoma, which is absolutely intramural, but this is not the standard. So before I come to meet you, I was trying to find some support to help me to convince you that myoma resection is needed and indicated. So I found this in Human Reproduction, which was an article by top authors in Europe about efficacy of hysteroscopy in improving reproductive outcome in infant. That was a systematic review. The conclusion was so frustrating to me. If I believe the conclusion of this paper, I will close my presentation and go home and I will not speak, because they said the systematic review found there is no evidence about the role of hysteroscopy for infertility evaluation. Don't be angry, wait with me. I'll tell you that these people are crazy, okay? I will prove it to you. It is unclear whether hysteroscopy before IVF can improve the live birth rate. There is a moderate quality evidence that hysteroscopy increased pregnancy rate before IVF. And they found a low quality evidence that hysteroscopy may increase pregnancy after removing submucosal fibroids. So these were the bullets into the heart of hysteroscopy. But I will not give up. You know, I find myself like Galileo. You know Galileo, who was telling that the earth is rotating, but all stubborn people were saying, no, the earth is stable. And he kept fighting the crazy old priest until the whole world said this man was correct. So my question to you, should we improve the quality of hysteroscopy or to improve the quality of your evidence? Who is telling us the evidence, Rishikesh? Because they keep Human Reproduction, American Society. Who is writing this article? Mr. Jones, Mr. Frank, Mr. Roberts, who are sitting on their desk and telling me how is it valuable to do myoma resection or no? When you listen to those people of meta-analysis and systematic review, they say, Osama, we do a lot of myoma resection and no improvement in pregnancy rate. My question, are you sure you are doing it well? This is the way, like if my wife is telling me, Osama, I am cooking dal and masala peanuts every day for you, but it tastes very bad. My wife doesn't know how to cook dal, all right? Or dal makhani or naan, or she doesn't know how to do it, all right? So the taste of dal from the hands of my wife is not like the taste of dal from the hands of Dr. Divya or Dr. Deepa, okay? This is the same. The results of myoma resection in the hand of Mr. X is not like Mr. Y. You got my point, Rishikesh? I'm talking philosophy now. I'm not talking science. I'm talking philosophy. And one more point. Everybody hear me or no?
Yeah.
Okay, one very important point. If you are evaluating laparoscopic myomectomy for fertility, okay? If you are very bad laparoscopic surgeon and you did a lousy bad laparoscopic myomectomy which ended in extensive pelvic adhesions, still this patient has a hope to get pregnant by an IVF, okay? But if you're an average moderate hysteroscopic surgeon and you enter this temple, the precious temple, and you destroyed the temple, you destroyed the endometrium, you did a bad myoma resection, there is no hope. I'm telling something very serious, Rishikesh. You will be the Foxy president. So you have to put this guy, the real guidelines. Not a moderate or average hysteroscopist should attempt to play inside the cavity with an electrocautery. You can play with the scissors, but it is only this small carpet, the 4 centimeters carpet, the endometrium. If it is destroyed, finished. So don't tell me that myoma resection is not valuable for fertility. Tell me who is doing it. Okay. I think what I've said is the most important part in my presentation about the logic. Again, laparoscopic myomectomy, if done badly, will not harm the fertility. But hysteroscopic myoma resection, if it's not done perfectly, I'm not saying good. If it's not done perfectly, the patient will lose total any hope for fertility. So this is one important point we have to care. And again, you cannot evaluate the results of a surgical procedure when there is a variabilities and no consistency in the surgeon's performance. Remember my story about cooking dal by my wife and cooking Egyptian food by you. So challenges with myoma resection. The space. In laparoscopic myomectomy, whatever the size of the myoma, I know that Nikita reported 7 kilograms myoma or whatever, Hafiz can remove an elephant myoma, okay, whatever big the myoma, still you can insufflate the belly more, you can find the space to go around the myoma and catch your pedicles, or you do the dissection and you do the morcellation later on. But in hysteroscopy, there is no space. If the myoma is a little bit oversized, we are talking between 3 and 4 centimeters, not 3 and 8. Between 3 and 4 centimeters, there is a lot of constriction, and there is no space to work around, like this one. So look what will happen now. Okay, space is created. So Dr. Jyotsna have gave a lecture about when to do hysterectomy, hysteroscopy, myomectomy, when to do the indication. I don't care about when to do it. My lecture is about how to do it. And then it's up to you to decide if you want to remove it or not. If you don't want to remove it, send it to me, okay? So first you have to create the space. When you create the space, you can access the myoma well and start cutting the chips. And cut from the most accessible part. Don't go to the restricted area. And when you cut the strips, push it far away. How to push it, Rishikesh? You don't have a retractor to push. Use the jet of the fluid. So that's why you should know how to play well and to navigate with the fluid jet, same like the car wash, the hose of the car wash, okay? So you can push this strips to one side. Why? Because if you keep going in and out, that will be terrible. Once you go out, cavity collapse, little bleeding. So when you go in again, the total view will be destroyed. You will not identify the anatomy. And it will take a long time to clean, and you will be impossibly able to get a full clean view. So try to finish from one insertion. If it's very crowded, then you can clean by some instrument and go again. For a larger fibroid like this, why we say that there is a limit for the size? One reason is the space. Second reason is the time. Hysteroscopic surgery, time is the crucial principle in surgery. It's not like laparoscopy, not like, nobody is telling this Rishikesh. People think that they can operate for 40 minutes. That's absolutely crazy. That's why patients die. That's why nobody can complete the surgery. You cannot do it like this. There is a restricted time because we are working against the clock because of the absorption of the fluid. The distension medium heat is fluid. It's not carbon dioxide. So you don't have the privilege to work for 1 hour. So if you have a larger myoma, the absorption of the fluid and the time will be long. I have a solution. Eat the myoma from one side to other side. So you convert the myoma from an apple by eating on the cheeks to a banana. And then you can go by an oven forceps and get, I did a case like this in Kolkata, and PC Mahapatra was attending with me, and he called the technique apple to banana technique by Shauki. Okay. Let me tell you one more important tips for the beginners, and sometimes even the expert, when they start cutting by the loop, they're a little bit afraid to take a deep cut. They are afraid of perforation. You will never perforate. You are protected by the myoma body. So those who are taking thin slices, like a potato chips, it will take longer time. Longer time means more fluid absorption, and you will be obliged to stop the surgery before you finish. One more thing, the more thinner the slice, the larger the number of the slices of the chips. So you'll have a very crowded cut. So instead of making potato chips, wedge potato cut, take a big cut, like this one. Look at this. Everybody look at how deep the electrode goes into the myoma to take a potato wedge. Look at this. You see that? You see how thick it is? So this is a potato wedge. I did a case like this in Leela. Actually, this case was done in Leelavati long time ago, all right? It was about 5 to 6 centimeter myoma, so it will take a longer time. This is beyond the indication of hysteroscopy for one setting. But when you cut by a thick slice like this, you can finish quickly. And this is the end procedure. You have this potato wedges and all myoma resected. Again, another case. This is to show you how the insertion. Slowly in, navigate, and look deeper how I rotate. I love to teach technique, rotate, like the corkscrew, and then you push in. I have a nice advice to help you how to measure the size of the myoma. Definitely ultrasound is an excellent tool pre-operatively, but during operation, the loop is 4 millimeter, okay, Rishikesh? This is 4 millimeters. So take the loop as a reference to measure how many pieces size like the loop. So tell you the size of the myoma. This myoma is lateral. So start from below and cut. Take a deep cut. You see that the myoma tissues looks white, not like the myometrium, which is pinkish. All my videos are non-edited, so this is about 10 minutes for total resection. Although you see I'm operating very slowly, but you finish quickly. You know, Rishikesh, the key success in such cases is to get a good view. You have to separate the uterine walls, okay? To free the space around the myoma, and then you can dance around, you can move. And this will achieved only by the proper, again, I say it, proper fluid pressure. I'm not saying high, I'm not saying low. Distension of the uterine cavity is one of the greatest challenges because in laparoscopy, once you achieve pneumoperitoneum, there is no leakage. The pelvic cavity is a closed, sealed cavity. There is no outlets or holes to escape the gas. But in hysteroscopy, the cervix and the fallopian tube is a huge leakage. So unless you have a backup good pressure by a good pump, you will lose that distension of it. So you have to distend well. So moving quickly. This is the myometrium. Everybody look, this is the myometrium. So this is the cut-off limit when to stop. Everybody, this is a very important view. Look at this. So this is the landmark to tell you stop. If you cut more than this, you are cutting into the myometrium. Either you will perforate or you might do something bad also. If you cut more into the myometrium, you have a thin wall and rupture uterus during pregnancy. So another challenge with the number of myomes, not only the size, if they are multiple. If you have multiple submucous fibroids, kissing fibroid like this, you see, these are kissing fibroid. If you remove both of them, you will have two opposing surfaces ready for adhesions and will cause an Asherman and intraenteric. These cases, it's advisable to do one by one and give a chance for healing, and then you attack that. These are multiple submucous fibroids. When the myoma is type 0 with a pedicle, actually, basically, we used to advise to keep the pedicle attached and don't cut it till you finish resection. Otherwise, if you cut the pedicle, you will have this dancing myoma inside. You'll not be able to catch it. Same like trying to catch a chicken. The chicken is running and you cannot catch it, okay? But recently, there are some opinions by good friends of mine. Dr. Sergio Hamovic from Spain is living in Israel now, and he claims that he did 500 cases of submucous fibroid, just cut the pedicle and leave it inside. Okay, I trust Sergio, I believe in him, but personally, I prefer to cut it into pieces and get it outside. You don't know what will happen if you leave a necrotic tear, but you have to believe also the literature. If he published this, we have to believe that and try to do it. This is a pedunculated fibroid. Very tempting to cut the pedicle. Very tempting to cut the pedicle. So you see, here my attempt is not to cut the pedicle, but just to do coagulation, cauterization of the pedicle. So that will help hemostasis. And then jump over the fibroid and then pull the electrode. What I'm telling now is very important. When you pull the electrode back by the working element handle, don't pull the electrode all the way back. Otherwise, the strip of tissues will be pushed to cover the lens and you will not see well. So just pull the electrode halfway, and then the whole system out. Again, this is technical point. Push the electrode beyond the myoma, squeeze the myoma by the electrode, and then by the working element, pull the electrode halfway, and then the whole system out. You can see this is the last remaining part of the pedicle. Myoma tissues look solid, white, no interlacing fibers, less vascularity, and you can use the electrode either by active electrocautery to cut or just mechanical push like this, mechanical push, and then it is detached. You have some very little fibers of the myoma. This is the myometrium now exposed. You will see that. This is little fibers of the myoma removed. And then you have these circular fibers of the myoma. That's a perfect, this case was done in Rainbow Hospital with Dr. Narendra Malhotra. You can ask him about this patient. She got pregnant afterwards with the help of IVF. So, challenge about when to stop. If you keep cutting, you will perforate. So your eyes should be very well trained to identify the myometrium. This is the myoma. And this is the myometrium. Look at this. This is the myometrium. These are the fibers of the myometrium. Again, keep cutting into myoma tissues until you identify the underneath myometrium. This is a big fibroid, at least 6 to 7 centimeters. And this is the myometrium. Okay, sitting in front of me is my assistant. His name is Yahya Shauki. My name is Osama Shauki. So it's easy that you identify that he's my son. And he's trying always to criticize. I said this myoma is 6, 7 centimeters. He said, Dad, no, it is maximum 5 centimeters. Whatever it is beyond the standard size 3 centimeters. Either you do it in 2 steps or 1 step. And when you reach the base, you see this terrible complication, bleeding. Look at this aggressive bleeding. So when you have bleeding in laparoscopic surgery, you can control easy because you have another instrument to catch and then another instrument for suction irrigation. But here you have only one instrument. So use the power of fluid, increase the fluid pressure to tamponate the vessel and cauterize, like this. Look at that. Where is the bleeder? You cannot see. When you increase the fluid pressure, that's the bleeder, okay? So now you can identify the bleeder and then you go and cauterize. That's it. This view is not inside the uterine cavity. This is the vagina. So this is the vaginoscopy view, and that's the pedunculated myoma coming from the fundus or from the uterine cavity all the way down. So vaginoscopy is a nice technique. I'm very proud that each and every gynecologist in India is doing this technique perfectly clear, and they get a lot of diagnosis which was not available by examining by standard cusp speculum. Now we will glide in cervical canal, slowly follow the myoma up, and that's the pedicle. You see, follow, oh, sorry. Again. Follow the pedicle all the way up. That's the internal os. And glide in. This is the uterine cavity, both ostia, fundus, and that's the pedicle. You see it, Trichy? Now it's very easy. Everybody feel tempted, Osama, give me scissor, give me a second, I can cut it. I know that everybody can do it now. But to reach this view, it took years of my life, all right? To reach this view, how to drive, how to use the fluid pressure. Another challenge, when the myoma is not inside the cavity. I'm finishing in 5 minutes by some difficult challenges. This is a type 3 myoma. Type 3 myoma is intramural, touching the endometrium. So according to the European Society classification, they say it's impossible. But ultrasound said that the myoma beneath this endometrium, posterior wall. So the myoma is somewhere here. Let's check by taking first bite. Here is the myoma, okay? You can see the indentation. So take the first bite. This is the myoma, obvious? So it's a very deep myoma. Look at the technique. I will show a picture now to let you imagine. Scoop out, like this. scooping the myoma from the deep intramural portion. And now you will see that's the myometrium, okay? So once myometrium highlighted, you know the limit when to stop. This is the cutoff limit. And this is the reference point which help you and guide you about this, to know the capsule of the myoma from the myometrium. So total resection was done and the myoma was enucleated. So the technique is very similar like the ice cream scoop. This is a type 3 myoma. The myoma is deep, below the level of the endometrium. So many cases of failed IVF, you find such small, tiny 1 centimeter submucous myoma. So if you use the resectoscope, you might impose or inflict more thermal damage to already weak endometrium. So a nice technique, using a scissors, just cut the endometrium, expose the tiny olive-sized myoma, and then go by a grasper, grab the myoma and don't pull out. No, push in, but not like this. Grab, down and in. Look what I'm doing. Don't blink your eyes. Keep looking at the myoma when it is delivered, which is excavated from the hole. Keep looking, it will jump now in. Exactly. That's the myoma, all right? Simple technique. People say can we do it in the office? Yes. I have another opinion about office hysteroscopy that I can speak about later. So the myoma is extracted outside, and this is the myoma bed, all right? So another simplification of this case is appreciated by the IVF people, because IVF people like simple intervention, right? Without damaging the endometrium. Another technique by the scissors. I can speak half an hour about this video, about the direction, the rotation. You go deep. Please look at the scissor jaw. Look at the jaws of the scissors, how they move. Cut and elevate, elevate until the whole myoma is free. And then I come to the finale, the final case of the day before I say goodbye to you. This is not an indication at all for hysteroscopic myoma resection. It is an intramural subserous myoma away from the cavity. So what is the driving force or the purpose to do it hysteroscopically? Not just like a muscle man to show skills, but there is another reason. This patient had a history of 7 laparotomies for previous myomectomies, intestinal injury, and a colostomy. So her belly is frozen, and she's for IVF now, but still there is this myoma, and IVF failed 5 times. So the doctors were desperate, and they said, we cannot approach this myoma in the frozen pelvis. So the idea came to my mind. I did 2 cases like this in India and about 15 more in my country, that you go by a scissors inside the cavity and you cut the fundus and expose the buttocks of the myoma. This is like the breech presentation, okay? And then try to deliver it. So this is the start. Here is the fundus. This is the fundus. And obviously there is some bulge in the fundus, okay? This is the imprint, indentation by the fibroid. Then you go by the scissors. All these white tissues are myometrium. So keep your eyes focused. So train your eyes about the shape of the myoma, how it looks. That's the myoma, see? This is the myoma, okay? So the myoma is very high up, deep intramyometrial, even subserosal. So cutting the edges from side to side, you expose the myoma very well, but still it's not delivered into the cavity. So here comes the challenge, Rishikesh. I thought that when I opened the window, the myoma will come down, and didn't come down. So I stopped the surgery. I told patient, go home and take misoprostol and come after 2 weeks, assuming that the contractions will expel the myoma. But unfortunately, it didn't come down. So the difference between inventor and normal person, only a second of thinking. When you think, you get an idea. So the idea came to my mind to insert a laparoscopy myoma screw, because there is no myoma screw for hysteroscopy. But the laparoscopy myoma screw is 5 millimeters. It doesn't go into the channel of hysteroscopy. So I dilated the cervix, hysteroscope, side by side by the screw, and that was really mission impossible. Enjoy this, my friend. This is the final. So you see how big it is. This is a laparoscopy myoma screw, side by side to the hysteroscope. Screwing the myoma, fix the screw into the myoma and pull down. Let's see if it will succeed or no. And it was really a mission impossible. It looks scary. Fix and pull down. And now look what will happen. It's coming. It is coming. Now myoma is getting delivered like the baby head coming from the vulva, like episiotomy, okay? So when it comes down, screw more and pull down. Look how beautifully it is delivered into the cavity. This is Om surgical myoma screw. I bought it from Mumbai. Or actually it was a gift from my friend Prashant Mangishkar, one of the great endoscopic surgeons I knew. So most of the myoma is delivered down now into the cavity. I will make it short. I will make it short and show you now the final view after myoma delivered. You will see a big hole, which is the myoma bed. Now, this is the uterine cavity after delivery of the myoma. Here is tubal ostium, and look at this. Look at this beautiful cavity. This is the myoma bed, nicely clean, myometrium, and no injury, no cauterization marks. I know that you enjoy this thing. When you decrease the fluid pressure, it will collapse. So everybody is now have concerns about the fundus of the uterus after a couple of months, because there was a big hole from the myoma bed. I cannot take sutures like laparoscopic myomectomy. So you depend on coaptation and spontaneous healing. So a second look after 2 months to show the fundus. Are you ready? This is the final slide. This is the second look after 2 cycles. That's it. This is the fundus. A little white color, but reepithelialization, covering of the cavity by endometrium, and this patient got successful twin pregnancy by IVF, completed till 36 weeks, delivered by cesarean section, and the babies are now 8 years old. So that's another mission for hysteroscopy. With all my respect to those who doubt and deny the value of hysteroscopy to prepare and clean the cavity before fertility, I say sorry for you. Please go and practice hysteroscopy good, and then you can judge. Again, for the last, you should know how to cook Indian food before you judge it is tasty or not. So that's my presentation. And before I go, I want to tell you, thank you very much. Rishikesh, are you happy? He is speaking in the phone to Rishma, because Rishma is telling him to bring the vegetables and the naan before he goes home. You should be a strong husband. Say, no, I'm not buying vegetables.
It was a really good, Ursama. I remembered all the days, and it was a fantastic presentation, I must say. And I remember the good old days, so it was good.
Unforgettable. You remember Leelavati and the Taj in Bandra, Carter's Road, and the Pani Puri on the street, Pani Puri.
I know.
Everybody,
we'll do it again after the COVID.
Sure.
Very nice.
Very
nice.
Yeah,
Felt
now
like,
I don't know whether to, yeah.
no,
Let's go.
Deepa, it was like watching a very
I want
nice
to
movie,
because
sir.
I have to start my office now.
Oh.
Yeah, now I don't know whether to call you Tom Cruise or James Bond, sir. So
Anybody.
Mission Impossible. I think you've proved that it's the man behind the instrument and the brain behind it that matters more for results. I think it's time we all stand in queue to have a training session with you very soon. It's been a fantastic, spectacular, I should say, spectacular presentation. Thank you so much. Thank you so much. Those were beautiful practical tips for
I
every
have one comment to tell Jyotsna, because me and Yaqub Khalaf are very good friends, but we always fight about this point. In IVF and protocols of IVF, you can publish results about the value of this protocol versus the value of the other protocol, because the protocol is standard and selection of the patients are standard. But in evaluating surgical technique, you cannot compare results with different surgeons. For example, the study of, you heard about the study, TRUST study. The TRUST study was designed to prove the value of correcting the septum, yes or no? It took 8 years, 17 participants. And these participants, some of them are IVF persons and some of them are endoscopic surgeons. The results of the endoscopic surgeons are very good. The results of metroplasty in the hands of the IVF person was very poor, showing that there is no need to correct the septum, okay? So you cannot get a conclusion out of that, you know? It's very difficult to evaluate results of a technique when it depends on variable skills.
No, I agree totally, Dr. Shawky. I totally agree what you're saying. I'm not disagreeing with what you are saying. But even a surgeon like yourself, who is so fantastic, do you have IVF or fertility data before or after? You know, you don't have to do a randomized control trial because this is quite tricky situation. It's not easy to randomize them. That's why I accepted at the very beginning that the variables are so many. How are you going to randomize them itself is a big thing. And just to say that you have to be based on all randomized control data is also unfair, because there are certain situations in medicine where you just can't randomize people and you just can't have data for everything. I totally agree with it. However, even if people like yourself who are experts, if they can publish their data, even before or after, at least we'll get some information to kind of help with these guidelines. You know, so I put people like yourself who are experts in the field responsible for such very, very, very important issues, because I am trained as a subspecialty trainee. So I'm a fertility specialist and a minimal access surgeon. So my module covers everything. So I have been trained for, and I agree, my resection might be better than somebody else, but yours might be better, will be better because you do so many. So it's a numbers game. So a technique can be taught to anybody, and not anybody. Some are generally good surgeons, to be honest.
Dedicated.
And
they should be
yeah.
dedicated.
So for us, for example, lots of surgeries are done by nurses. Colposcopy is done by nurses. Outpatient hysteroscopy is done by nurses. You can train anybody who has a little bit of hand-eye coordination. But as a clinician, it's yours and my job to decide who needs to be operated and whether it is beneficial, and to inform her that I think it is beneficial, even though the guidelines say this or the data say this, but in my hands, in my experience, I can make it better for you. So that is where I stand. I'm not telling everybody not to operate. I'm telling that is where the guidelines are, because unfortunately, there is nobody there willing to do studies, or nobody else there is willing to publish their own personal data, which is kind of sad. That's all I'm saying. But I think it's time to move on to Dr. Pai. And I think, please introduce him because he's been bearing us for a long time.
Yeah, thank you, Dr. Osama. Thank you, Dr. Jyotsna, for that little debate of yours. I take pleasure in inviting the next doyen for today. He is no new person to the Foxians and to Indians. He's the ART man of India, I can say. with so many cycles of, I think, thousands and lakhs of cycles of embryo transfer ICSI at his credit. He has won extraordinary awards. To name a few, I think I'll be doing injustice if I can just name a few. I would just talk about his major achievements. Dr. Rishikesh Pai was awarded with the esteemed fellowship or addendum of the RCOG, Royal College of Obstetricians, London, UK. And he's been the past Secretary General, Senior Vice President, Deputy Secretary General, Treasurer, Chairman of FOXI, past President ISAR, IAG and MOGS, and he's been awarded 30 plus awards, including the prestigious Lifetime Achievement Award for Outstanding Research in Reproductive Health by ISSRF. And recently, again, he has won on the world on this recent World Population Day. He has again won the Guardian of Health Award in the presence of Union Minister of State for Social Justice. He has got a digital award. Congratulations, sir. I think he's a very well-known person in the FOXI circles. He's been with FOXI for the last 20 to 30 years. And a good Samaritan, a great philanthropist, and a very down-to-earth person, always wearing a beautiful smile on his face. To those of you who don't know, his father is a Padma Shri awardee and his mother is a freedom fighter. Both of them are freedom fighters, and I'm sure the next in line to win a Padma Shri would be you, sir. And we wish you great future and more accolades. Over to you, Dr. Rishikesh Pai. He's going to talk to us about the non-surgical management and ART in fibroids. Over to you, Dr. Rishikesh.
Thank you. Actually, I would like to say that I would like to first thank Dr. Vidya, then of course you, Deepa, and my two very good friends, Dr. Jyotsna and Dr. Osama. They come from different backgrounds, and I would say that probably I am the bridge between them two. The two different concepts of practice are, one is the actual practice, and the other is the also practice, but it is a research kind of practice. And what we need to do in the future, what has happened now in the last 20 years, because a lot of us as surgeons, we were very busy on our private practice, so we did not publish, and that is one of the biggest flaws that happened in the last 20 years of evolution of medicine in all lines, I would say. And we didn't have the time. We were trying to build our careers, and at the same time, we also, our profession didn't classify disease properly. And fortunately for us, in the last 20 years, the classifications have taken place now. Now we know the grades of the fibroids. And based on the classification, now we understand, slowly we have started understanding the language, what Jyotsna speaks about, the language of meta-analysis. And we understand also that what we are doing in our clinical practice is relevant, but we need to prove and we need to bridge the gap between understanding research and understanding practice. And I think that as a FOXI president, that's my vision, because what I've realized as I've evolved, so I've evolved in a reverse fashion. Most of the time in the West, in UK, USA, you evolve, you get trained research, and then you slowly evolve, and then you publish, and then you enter private practice. In our third world countries, we do it reverse. We go into private practice, we build a practice, and then at the end of our career, at the twilight stage of our career, we start building our research, but the time is not enough. So our future generations in our countries, we need to train them in research. We need to classify the disease so that, and we need to understand from people like Jyotsna, we need to learn from people like Osama, the skill of the surgery, and we need to integrate the two. We need to devise studies which are prospective, randomized, using our skill, using our classification of disease, and come out with a conclusion. And that is what we need to do. We need to integrate ourselves. So coming back to my talk, it is on fibroids, and the easiest thing to do is just take the fibroid out, God damn it, and just do the procedure. But if you look at the classification of disease, and this was Monroe's classification actually in 2011, and Figo then took this classification and decided to classify. I will not go, but the submucosa 0, 1, 2. Then the 3 is, it's just touching the endometrial lining, but it is intramural. 4 is purely intramural, 5 is subserosal but more than 50% intramural, 6 is subserosal but more than less than 50% intramural, 7 is most of the time pedunculated, and 8 is other, and 2 to 5 means it extends from the endometrium to the subserosal. So these are the classification. And if you look at the presentation of fibroid, there are many presentations. Many of them are asymptomatic, but you can have abnormal bleeding, pelvic pain, and some of them can present with infertility. There are fibroid, and they are infertile. There's no other cause of infertility, and maybe the fibroid is causing the infertility. This is Dr. Pai's classification, wherein I've integrated the ASRM Practice Committee report of 2008 and the beautiful, one of the most important persons in this field of fibroids is Jack Donez. And if I looked at Google and I see the evolution of his thought process right till the 2020, he has got a RBM Online article in 2020 as well. So I integrated. If you look at the classification of fibroid, you have the non-uterine cavity fibroid factors. You have non-uterine cavity factors which can cause infertility, displacement of cervix, obstruction of the proximal fallopian tubes, altered tubo-ovarian anatomy interfering with ovarian capture. You can have distortion of the uterine cavity, and this is normally fibroids type 0, 1, 2, and 2 to 5 extension. And in this, there are mainly mechanical obstructions to sperm migration and problems in blastocyst implantation. Submucosal uterine leoma have additionally a global effect on molecular determinants of endometrial receptivity. There's a global decrease in the endometrial Hox gene expression, and there is a disruption of the endometrium and implantation due to atrophy of or venous ectasia over or opposite a submucous myoma. There can be endometrial inflammation or secretion of vasoactive substances. So you have the distortion of the uterine cavity, and then you have the non-distorting uterine cavity factor. So there may be an intramural fibroid which is not distorting the cavity, but it still causes infertility. And what are those causes? How does it act in that particular situation? And these fibroids are type 3, 4, 5, 6. Impaired endometrial myometrial blood supply can be there. There can be increased uterine contractility that may hinder sperm or embryo transport and nidation. There may be hormonal, paracrine, and molecular changes by altering glycodelin. This is a very important molecule, and bone morphogenetic protein receptor type 2 gene expression. And there may be impaired endometrial receptivity and gene expression. This is very important. Fibroids produce a growth factor called TGF-beta, which acts as a diffusible. It diffuses through the fibroid, through the myometrium, and enters the endometrium. And this is a diffusible signaling molecule which alters BMP2, reduces HOX10 expression throughout the endometrium, and subsequently interferes with implantation. Large fibroids produce more TGF-beta3, and those closest to the uterine cavity allow the TGF-beta3 to reach the endometrial cells. So the location as well as the size of the fibroid is not so much due to the mechanical expression of the fibroid, but because of the production of the TGF-beta3, which diffuses into the endometrial cavity. And of course, a thicker capsule, because fibroids have a pseudo capsule, and if the capsule is thicker, it may cause muscular contractility and uterine peristalsis, which may cause expulsion of the embryo, and that can also infertility. Well, how do you investigate it with a 3D? It's given a standard ultrasound or 3D ultrasound. CT is not relevant, but MR is a very important diagnostic modality, though there is no definitive MR finding which can actually also diagnose sarcomatous change in a fibroid. There are various parameters that you can have, but you can never be sure about a sarcomatous change in a fibroid. Do fibroids influence fertility outcomes? In general fertility as well as IVF. So I'm talking about, so there is this landmark paper by Elizabeth Pritz in Fertility Sterility 2009, where she concluded that fertility outcomes are decreasing in this mucosal fibroid, and removal seems to confer benefit. Subserosal fibroids do not affect fertility outcomes, and removal does not confer benefit. Intramural fibroids appear to decrease fertility, but the results of therapy are unclear. More high-quality studies need to be directed towards the value of myomectomy for intramural fibroids, focusing on issues such as size, number, and proximity. So I'm going to go take you from the evolution. Elizabeth's landmark paper, and I remember in 2008, I was reading it in Fertility. I was giving a talk in the AICOG, one of the AICOGs on fibroid. And from there onwards, from 2009, how has the concept evolved of the fibroids causing infertility? So treatment of submucous fibroids, is it beneficial and should it be done? Since the publication of the review by Pritz and the clear message that women with submucal myomas experience significantly lower implantation, clinical pregnancy, ongoing pregnancy and live birth rates, as well as significantly higher miscarriage rates, the need to treat submucal fibroids is widely accepted. We understand more or less, even though there may not be ascites, we understand that lot of publications have said that yes, the submucous myoma should be treated. And there's a paper by D. Spizzo et al. In Obstetric Gynecological Research in 2015, where he has said that with the development of hysteroscopic techniques, type 0 and type 1 myomas as a primary approach is good enough. And in the case of type 2 myomas, where more than 50% is intramural, distortion of the cavity occurs, so resection is indicated and may be facilitated by pre-operative medical treatment. You know, in order to reduce two-step procedure, you may give pre-op medical treatment, reduce the size of the fibroid, and then remove it. Especially, you can use selective progesterone receptor modulators or GnRH agonists. And this is a paper by Donnes in 2016. Does type 3, 4, 5, 6 fibroids improve fertility and IVF outcome? This is a question we need to answer, and most studies are selective as well as heterogeneous as large fibroids. In most of these studies, the large fibroids were anyway knocked out. So if there was a 7 centimeter fibroid, it was already knocked out. So that created a problem in interpretation of result. And there was this landmark paper by Sunkara in 2010, where she did a systematic review of 19 observational studies involving 6,000 IVF cycles. And she showed a significant decrease in clinical pregnancy rate in women with non-cavitary distorting fibroid, means a standard intramural fibroid not distorting the cavity. However, her conclusion was there was no reduction in IVF success rate. So even if you left this fibroid behind, IVF success rate was not affected, and they did not suggest removal of fibroids prior to IVF. So there was a bit of a controversy. And then in 2017, Christopoulos et al. In an observational study in BJOG, he says that it was found that the deleterious effect of non-cavity distorting myomas on live birth rates was significant in women with 2 or more fibroids and in those with fibroids 3 centimeter or wider in diameter. So the 3 centimeter classification, there were many who looked at the size of the fibroid, and the 3 centimeter classification was brought in by Christopoulos in 2017. And then Yan et al. In 2014 said that type 3 fibroid also, so a fibroid near the endometrium can also have a negative effect on clinical pregnancy and live birth rates, particularly if the single fibroid diameter or total reported fibroid diameter is wider than 2 centimeters. So he said that if it is near the endometrium, even 3 centimeters, no, even a small 2 centimeter can also have an effect on fertility. Thus, treatment, again, if you continue the discussion, a retrospective cohort study by analyzing a total of 929 fresh single blastocyst transfers were done, and they concluded that intramural myoma may affect clinical pregnancy and live birth rate. This was by Beheberani in 2018. And then a Wang's landmark meta-analysis was done, which totaled 28 studies involving 9,189 patients. And he concluded that a non-cavity distorting intramural myoma significantly reduces implantation and clinical pregnancy and live birth rates following IVF. And this was supplemented by Rikharaj's study in 2019, where he did a systematic review of 15 quantitative studies with a total of 5,000 patients. And he concluded that patients with non-cavitary distorting intramural fibroids undergoing IVF had a 44% lower odds of a live birth and 32% lower odds of a clinical pregnancy than women without fibroids. So in conclusion, all published studies and meta-analysis concur that non-cavitary distorting intramural fibroids do have a deleterious effect on IVF outcome. Let's conclude that. 2 factors seem to be the key, namely the size of the myoma If larger, there is a greater secretion, as I told you, of the molecule TGF-beta-3, and the close proximity to the uterine cavity. So the proximity to the endometrium and the size of the fibroid is very important. Close to the endometrial lining, a type 3 myoma of 2 centimeters or more will have a detrimental effect, even if it is smaller, but if it is close to the endometrium, it will have a detrimental effect. If a myoma is intramural, but not in contact with the underlying endometrium, that is type 4 or 5, a diameter of 3 centimeters is considered to be the cutoff, depending on the study of the meta-analysis. Different meta-analysis have a 3, 4, 5. Personally, I have a 4 centimeter cutoff, but a 3 centimeter cutoff there. And in 2018 has shown that several investigators have therefore recommended surgical removal of these intramural fibroids. The crucial question, and this is the moot point of my presentation, the crucial question, however, should be that if the negative effect is related to the myoma size, even a 3 centimeter size, and proximity to the uterine cavity or nearby the endometrium, why not try a medical approach of ulipristal for 3 to 6 months, or another medicine like ulipristal to reduce the size of the myoma and push it back deeper into the myometrium, thus improving outcome of a spontaneous pregnancy or a pregnancy following an IUI or ERT procedure without surgery. Why do we need the surgery? Can we not do it medically? And this is the Donis in 2016. Donis proposed this idea. And if there is no reduction in size, obviously we can go ahead and do surgical removal. So if we look at the medical procedures that are available to us, we have the conservative management. You can just, a patient comes to you, she doesn't really bother, doesn't want to have a pregnancy. Okay, you conservatively manage her, observe her, do a follow-up ultrasound and forget about it. What are the medical things that are, there are many, but the 3 landmark medicines that are used, depot GnRH agonist, the ulipristal, and the oral GnRH antagonist. And then we have the other modalities like MR focused ultrasound or ultrasound focused surgery, uterine artery embolization, transvaginal uterine artery occlusion, cryomyolysis, and radiofrequency ablation. So what are the indications of medical management? One is stopgap arrangement for treating anemia and pain. Patient comes to you, she is having a lot of bleeding, pain, anemia, 7 gram hemoglobin. Prior to myomectomy, you can give her medical management and, and stabilize her. Pre-treatment of type 2 myoma, size more than 4 to 5 centimeter fibroid prior to hysteroscopy. So a large hysteroscopic type 2 myoma, you give pre-treatment with medical, reduce the size, and then you can maybe try a single sitting removal of that fibroid. As primary treatment, and this is very important, as primary treatment for type 3, 4, or 5 fibroids, which are in the range of 3 to 5 centimeter. This is the gray zone area. More than 5 centimeter, we know we are going to remove it. Less than 3 centimeter, we know it's not really going to make a difference unless it is protruding into the uterine cavity or it's very near the endometrial cavity. In patients who want to try getting pregnant, either spontaneously or with iron, no one wants to do surgery. If you have a toothache, do you want to go and remove your tooth? You will take an antibiotic, you will try any medicine. If that fails, then you will go to the dentist to remove your tooth. Patients not wanting to undergo surgery, they don't want to postpone or avoid surgery. Avoid recurrence after surgery in women at high risk of recurrence. Sometimes recurrence is there, so we want to avoid. You can't keep on doing surgery. Or in patients where they are genetically predisposed for occurrence like Afro-Asian. In patient where surgery is contraindicated, she may have a medical disorder. Patient wanting to postpone, she may be married, she wants a childbearing function, she has a fibroid, but she is not really interested in having a child right at the beginning. She wants to postpone having the child. So if you look at the medical things that are available, progestins like danazol, DMPA, liquid nitrogen, LNG, IUCD, then GnRH analogs. Then we have the selective progesterone receptor modulators, mifepristone, ulipristal acetate, asoprincil, and telapristin acetate. Then you have the aromatase inhibitors and the SERMs. But if you see, there are only 3 landmark medicines which are there. And we'll focus on these. One is the GnRH agonist, which is our standard depot preparation, which alone or more commonly with add-back. You give it with the estrogen and a neta, it is known as norethistérone, and is used preoperatively to reduce the fibroid sites, correct anemia, and render safe surgery. However, these drugs may also make surgical enucleation difficult due to loss of the surgical frames, and hence most surgeons do not prefer it, as a surgical dissection may become difficult, and very small fibroid may disappear, lose those fibroids, and you may end up leaving those fibroids back. It can be administered for 2 months prior to IVF. So in my unit, I do a lot of frozen transfers. I do the surgery, I do the IVF, I freeze the embryos, and then if there are small fibroids, I'll give them 2 shots of depot and then transfer, because of the depot or the size will go down, and I then transfer the frozen embryos and get a quick pregnancy. Main side effects are bone demineralization and hot flushes during prolonged use. These can be counter add-back therapy. The effect on fibroids are also temporary, and if you stop it, it will come back. So there's a temporary effect. Then came the ulipristal acetate. It was introduced in 2012. It is a selective progesterone receptor modulator. It acts on the progesterone receptor of the myometrium and prevents stimulation of fibroid growth by inhibiting cell proliferation. It also causes a non-malignant reversible in progesterone receptor modulator associated. So there is a PAECS, which is there a change, which is an abnormal change in the endometrium called PAECS, progesterone receptor modulator associated receptor changes, and these are reversible in 2 months time, and normally prescribed in a dose of 5 milligrams a day. You do it, take it for 3 months, then you can take a break. You get multiple batches of 3 to 4 cycles of 3 months with 2 months gap period, and slowly the fibroid may go down in size. However, what was a big problem that occurred in 900,000 patients? There were 5 liver failures which needed liver transplant. And then in 2020 March, the European Medicines Agency, EMA, has temporarily stopped it. It's a beautiful drug. Just those 5 liver transplants due to liver failure has suddenly brought a beautiful drug to a standstill. But there is a hope on the horizon. And that's the biggest, I think, one of the biggest breakthrough. I keep on telling my pharmaceutical friends, I said, if you are going to get a drug, and let me tell you, I was the person I suggested to a lot of pharmas. Some of the drugs brought into India are into my suggestion. And this is a breakthrough drug. This is a landmark drug. This is the oral GnRH antagonist. And there are 3 of them: elagolix, relugolix, and linzagolix. They are all in various trial stages. Ilaris 1 and 2 is the trials for elagolix. Liberty 1 and 2 are the trials for relugolix. And Primrose 2 is the trial for linzagolix. And these are going to change the treatment of endometriosis. It's going to change the treatment of fibroids. It's going to change the treatment of IVF. So this is a new beginning. And so far, they have been shown to have a rapid effect. Only problem is it's bleeding, but it does not reduce the volume of the fibroid. Of course, there is a study which has come from the Osuga group, where he has also shown the decrease in the size of the fibroid. So these are certain medical. So we have the 3 medicines. The ulipristal has been stopped at present because of liver transplant. They are looking at they had given a guidance that you should do liver monitoring of the liver during the therapy. But despite of the monitoring, recently failure with a liver transplant occurred, and that's why the EMA gave the guidance to stop the drug so that they can have the drug. Then you have the magnetic resonance imaging guided focus ultrasound. This was introduced in our Mumbai in Jaslok Hospital, where Rishma, my wife, past president of Foxy, you all know her. She's there along with the radiology department of Jaslok was there, Srinivas Desai, and they have been doing a lot of work on this. It's a non-ionizing radiation. You just focus using an MRI. You can focus on the fibroid, and that can actually reduce the size of the fibroid. You need to just keep the patient in prone position, and then you put it's a high intensity focused ultrasound transducer in the tabletop. Patient is prone. Treatment is performed under conscious sedation. Targeting is done using MR imaging. Treatment monitoring is done using MR thermometry. And tissue is destroyed following multiple ultrasound sonication. Takes about 2 to 3 hours, and patient goes home the same day. Indications are for symptomatic fibroid, and it can be an alternative to surgery as well. And this was a study by Rabinovsky in 2010, where he showed a lot of live births. And I would like to show you another study as well on that. The live birth rate, there are not much side effects, but very rare complications are there, like 2nd, 3rd degree skin burns can be there, and very rarely, if the bowel moves, there can be a bowel perforation as well. The other one is the uterine artery embolization, which can also be done, and is done using polyvinyl particles. However, the guidance is that for patients who want to have children in the future, there's a higher incidence of miscarriage rate, and those people who want fertility should not use this as a treatment. You also have other things like cryomyolysis, radio frequency myolysis, temporary transvaginal occlusion of uterine arteries, but these are all esoteric things and it really doesn't make a difference. This is a beautiful systemic review case which has come by Kaur et al. In RBM Online in 2020, and he compared the pregnancy outcome after fertility preserving treatments for uterine fibroid. Data were available on 12 pregnancies after UPA. Now actually there are 150 pregnancies, 1,500 pregnancies following myomectomy, 424 following embolization, and 420 following fibroid ablation, that is ultrasound focused MRI ultrasound. And high rates of successful pregnancy were seen after myomectomy, 75%, fibroid ablation, whereas the pregnancies after uterine artery embolization had the lowest live birth rate and high miscarriage rate. So the conclusion was that myomectomy is the gold standard to preserve fertility with the best pregnancy outcome. Fibroid ablation may be offered to women where there are contraindications to surgery. Uterine artery embolization is associated with poor pregnancy outcome, and there are too few reported pregnancies after ulipristal acetate, and as I told you, the drug has been stopped at present. So does fibroid removal impact outcome? And there is this study by Sware et al. In Fertility Sterility, where he has shown that he carried out a retrospective case-controlled study for women with submucosal fibroids undergoing an IVF using own or donated eggs. And in this group of women, implantation and ongoing pregnancy rates were similar to the controls who had no fibroids, suggesting that the detrimental impact of submucosal fibroids is eliminated by removal of the fibroid. There was another study by Bostel's Cochrane review of 2015, which was a comparative non-randomized study assessing the potential benefits of myomectomy for intramural fibroids. 168 women, and this is very important, with at least one fibroid more than 5 centimeters were allowed to choose between myomectomy and expectant management. Mucosal fibroids were excluded. In the 84 women who had myomectomy, clinical pregnancy and delivery rates were significantly better after 1 to 3 cycles of IVF treatment. Does fibroid removal impact IVF outcome? Women are usually advised to avoid pregnancy for at least 3 months after abdominal myomectomies, resulting in delays in the planned IVF treatment. This may potentially be an issue for older women, particularly for those with reduced ovarian reserve. So, the woman with reduced ovarian reserve, what I do is I do the IVF, I'll collect the embryos, and then I will remove the fibroid. After 3 months, I'll immediately do the transfer. And this is also good for patients where there is high incidence of recurrence. So what is my approach for removal prior to IVF? I remove all submucous and cavity distorting fibroids prior to IVF. I remove all fibroids, more than 7 centimeters, I knock them out, or those that will come in the way of oocyte retrieval, including subserous fibroids prior to IVF. So if there's a subserous fibroid, I'll not touch it, but if it is going to come in the way of the IVF retrieval, I'll remove it. Removing more than 4 to 5 centimeter intramural. So now comes the controversy. So if there's a 4 to 5 centimeter, my cutoff is 4, let's have a 5 cutoff. Some people like Donets have a 3 centimeter cutoff. So 3, 4, 5 centimeter intramural non-cavitary distorting fibroid, you can remove it prior to IVF. IVF should be performed after 3 months of surgery. What do I do for the 3 to 5? So that's the controversy. If a fibroid is between 3 to 5 intramural, you can try one IVF cycle, not touch the fibroid. If it fails, then prior to the next cycle, you may remove it and do the transfer. Try one IVF cycle without surgery in patients with sizes between 3 to 5 centimeters. You can expose them to medical management also. Try to reduce the size of the fibroid. If one cycle IVF fails, we would remove all fibroids prior to the second ART cycle. As I do, so what are the future plans of mine? The submucous type 0, 1, 2, and 2 to 5, you do surgery. Intramural cavity distorting type 3, 4, 5, you can do surgery or you can do MR focus ultrasound. Intramural non-cavitary distorting type 3, 4, 5, size more than 4 to 5 centimeters, surgery or MR focus ultrasound. Intramural non-cavitary distorting type 3, 4, 5, less than centimeters, you can wait and watch. This is very important. Intramural type 3, 4, 5, size between 3 to 5 centimeters. You can do medical treatment, and this was the thesis which was proposed by Donets, that you can do medical, give them 3 to 6 months of medical treatment, ulipristal. Now, after the analysis of the EMA agency, and if they think that ulipristal is safe for use, then you can use Ulipristal, or by the time the GnRH antagonist oral comes in, you use GnRH antagonist oral, and you can give it for 3 to 6 months. If the size decreases in size, many of them may spontaneously conceive or may conceive by IUI or IVF. And if the size doesn't decrease in size, you can go for surgery. Subserous type 6 and 7, only in those patients which come in the way of the ultrasound, you can do surgery or MR focused ultrasound. So in conclusion, and this is very important, the mystery surrounding intramural myomas remains, and only prospective randomized studies investigating medical versus surgical therapy will address the question of the best approach to take in the case of intramural myoma related infertility. But that doesn't mean we stop the studies. It's just that we understand, as Josna said rightly. So we have Josna and we have Osama. We have to let Josna and Osama continue operating together, and person like me integrating it and evolving the thought process as to what is the right path to take in the future. Fibroids, however, are a common pathology and increasingly observed in women requiring a medical plan for infertility for 2 reasons. Longer reproductive timelines in women thanks to improvement in medical care, and the current trend. Many women are postponing childbearing, want the childbearing, but they don't want it. So they have got the fibroid, but so we have to handle these fibroids. We have to, if they are symptomatic, we'll have to use medical management to keep it in control. We can't just go and do surgery and say, okay, I will do surgery today and you can have a child 5 years later. So we have to use a medical management to handle and continue and control the fibroid. The development of new algorithms for intramural myoma related infertility are urgently needed, as is the evaluation of the place of medical as a primary approach. And finally, then depending on the response to medical therapy, remaining myoma size and patient conception or IVF if required or surgical therapy can be proposed. I would like to thank all of you for a very patient hearing.
Thank you, Dr. Rishikesh Pai. It was a wonderful, I mean, like when we were listening to Osama, it was like hysteroscopy was the best method. Now, when after listening to you, we think the medical option is again good. So I want one of you all to give us the consensus, either of you or even Josna. Josna is again sticking on to the guidelines. So we want some consensus from 3 of you all. Who can give?
Okay, I'll start.
Yeah.
I'm not saying that you must stick to guidelines, because then there will be no progress in medical fraternity. Okay, yeah. So I just put it there, what is there. Yeah. But what Dr. Pai has said is actually brings everything together, especially the last couple of slides where he said what he does in his personal practice. It's important to acknowledge that it's your personal practice, and how I do. So what Dr. Pai has said is that's what most of it I stick to as well, except the 3 centimeter fibroid. I might be a bit on the fence. However, as a place where we work or as a philosophy we work, we must tell the patient that I think it will help you, but there's no clear. See, what happens is if these cases go to medical legal court cases, then everything comes from the evidence-based side, you know? So it's my duty to tell her that based on these guidelines, there's no concrete evidence. However, you had 1 or 2 failed IVF cycles. I cannot see anything wrong here else. So maybe if I remove this fibroid, it might improve your chances. And if you're willing to do it, I will do this. So this is where the whole thing comes up. So I'm not saying that just stick to guidelines, just don't touch. And again, Dr. Pai corrected very clearly, subserous fibroid, that's exactly where if you can't reach to ovary because there's a fibroid sitting there, you have to go and remove it. Not have to, but you would want to go and remove it because you want to access to the ovaries. So it's not hard and fast rule. What I'm trying to say is be aware that that is there because we don't have data. However, all of us do practice, but for us, we have to inform the patient, and our information booklets reflect the same. So I think Dr. Pai's slides have kind of nicely summarized the current suggested practice. And Dr. Shawky is, as you know, his tips and techniques are already there for at least a hysteroscopic one. Medical one problem because of SMIA has been withdrawn. even though Dr. Pai's topic was medical, but you can see very clearly that he does lots of surgeries and he has an inclination towards surgical approach anyway. And sadly, has been stuck with a topic where he had to talk about medical one. But I think his slides at the end summarized it very nicely.
Yeah, thank you, Josna. What Deepa, you have to say?
I think Dr. Osama can remove anything from below, so that gives him the.
Little thing, please. Little
Yes.
thing. Rishikesh, in my country, long time ago, the title of the doctor was not doctor. They don't say doctor. They call Hakim. What's Hakim in Arabic? Hakim means the wise man. Okay. So the title of the doctor was Hakim. They're Hakim, not doctor. Hakim means the man who is wise, not only have science. Science tell you rules, okay? But wisdom tell you how you apply these rules. Let me give you a little example. If the evidence and guidelines say that the 3 centimeter myoma is doubtful to affect fertility, okay. And you will give her a chance, couple of years or 2 or 3 years. These are the guidelines, okay. Have you thought about her age and AMH? A patient of 38, 39, and 3 centimeter myoma. I will not waste time. I will not waste. Okay, you can get pregnant. There is a chance. But if you become 42 and not pregnant, now my chance with IVF will be lost. Okay.
Totally.
So you can. Jyotsna is different than me and you in one thing. She work in UK. All right. If you violate, okay, you'll go to the court next day, all right?
No. My problem is if I leave 38-year-old doing nothing and send her home for 2 years, that's also not right, because then she'll sue me that I have done that. So I agree. I put everything has to be put in context. You can't send 38-year-old home. But
we have to be wise in handling the science, the evidence, and I'm a professor in the university, so I have an academic title, but I'm the only one who is rebellion that I say, I respect the evidence, but I trust the experience more, all right? For example, if the whole evidence tells that no need for episiotomy, you know this story? The episiotomy story in the evidence, okay, if the whole world say no need for episiotomy, and Dr. Sunawala, you know Dr. Sunawala? Sunawala, you know him?
Yeah.
Say his name.
Everyone knows Sunawala, yaar.
Okay. If he tell me, Osama, you have to do episiotomy, I will follow him because he did thousands of this man, I know him, I saw him, I saw his hand, I know his result. So I will trust him. So this is my advice for the juniors. But I cannot tell any junior to say, my experience, you're still a junior, all right? So I will want the opinion from Rishikesh Pai about how to handle special situation, age, AMH, okay, previous surgery.
Very nice.
Osama and Josna and all of you, I have already summarized it in my talk about how to handle it. What I am saying to all the juniors is that you have to learn the skill of Osama, Prashant Mangeshkar. I would like to tell you a very anecdotal thing that my first, skirmish with hysteroscopy was when I was I had just finished my registrar's post in 1985. Alan Deshani had come to India and he demonstrated first time in the hall. Me and Rakesh Sinha were present and we were aghast when we saw that resection. And then Rakesh and me more or less bought the resectoscope at the same time. Of course, I was more towards ART and Rakesh became a great surgeon. Wherever he is, bless his soul, he was a fantastic surgeon. So Rakesh, there were 3 great surgeons which really set the trend of endoscopy in India. One was Rakesh Sinha, second was Prashant Mangeshkar, and third was Prakash Trivedi. No doubt about it. I used to call them the trio of endoscopic surgery in India, and they did it. So the endoscopy. So I had this, and then I went in 1998 to Stefano Bertocci, and of course Osama was my friend. So the skill. So for the juniors, you must learn the skill of surgery. That is Osama, but at the same time, you must learn the application because the times are changing. We are now slowly going. What Josna has said is correct. And this is what is my as a Foxy president, what am I going to do? Actually, I tried to do it during Nandita and during Rishma's time. We need to publish the protocol, because if there is a litigation that happens tomorrow, a patient dies on the table, you are removing a 4 centimeter intramural fibroid, and that goes to court.
Yeah.
The court will give you a judgment against you because there is no evidence. We need to publish that. So the Federation of Gynec Societies of India need to publish that evidence and say, yes, as far as Foxy is concerned, a 4 centimeter intramural fibroid should be removed. And that is what is my objective, if at all. If Santa Kumari does it before me, or if Alpen does it before me, great. But if they don't do it before me, I want to publish everything possible so that if it goes for litigation tomorrow, my colleagues will be protected in this country. This is my objective. Ultimately, when you become a president, you have an objective in life. You need to, when you go away from the organization, people should remember you for something. And I want to bridge what Osama's comes from a traditional saying, what the hell, what is this all nonsense? I'm a great surgeon and I've done so many patients. Yes, we need to learn from people like him. He needs to teach everyone. But we also need to have when my son Jasna has become resident, what I told him, while he went to the college for training, I said, listen, you learn. But most important thing, you need to learn to research. This is where we all lack. Our country lacks in research. We are highly skilled, but the research is also important because it gives us credibility. We need to publish. We don't publish. That's why our credibilities are zero. And I always feel bad. I'm on the board of International Federation of Fertility Society, but when they decide to give a talk, they don't give the talk to me. I've done 20,000 oocyte freezings, 20,000 oocyte. They will give a talk to Anna Vega because why? She published and I didn't. We both started freezing on the same day. When I went to Tokyo, on the same day Anna Vega's team had come, me and Richman had gone. Both of us trained from Masako on the day, learned freezing. I came back and I did 20,000 oocyte, but I have not done a single publication of that oocyte freezing, while Anna Vega has done 20,000 publications. So her credibility is important. And my credibility is what? My credibility is zero because I didn't publish. This is what everyone in India should understand. All of us have to publish, and also learn from people like Osama, Mangeshikar, Trivedi, Hafiz, Sanjay Patel, and also operate. Operation surgery is also important, but publication is also equally important. This is what I want to say to everyone.
Very nice.
I don't want to interrupt this. I don't want to go outside the discussion, but a little question to Jyotin and Rishikesh, and don't answer me now. Go and Google. I think all of you know the story of the editor-in-chief of The Lancet. Deepa, you know what he said? The editor-in-chief of The Lancet, the editor-in-chief of The Lancet, after 20 years, he came up with a statement and he said, I feel very sorry to tell you that more than 50% of what you read in the journals and the publications are not correct, are fake, and are not true. This is The Lancet, okay? The editor-in-chief. I don't want to make a revolution.
Osama, what we need to do. I agree. What we need to understand is that it's important to publish whatever for example, we read. It's important to publish at the same time. It's important to learn from people like you also. So it is an integration. We are complementary to each other. We are not at the same camp. Ultimately, women's health we are serving. So we together, and this is our new generation, should bring all the people together, integrate them, and have one single thought process and go ahead and serve the women's health. There should be integration of thought process, integration of implementation should be there so that everyone gets the best of everything. That is what I'm saying. What you do is very good. Removal of fibroid. Where is the question? I'm just saying that we need to have a protocol. We need to defend ourselves. Tomorrow, if there is a litigation, hysteroscopy, someone dies of fluid overload, we should be able to say, yes, we did the surgery. Judge will say,
according to the guidelines.
The surgery, was it indicated? We should be able to do that.
Okay, Dr. Pai, thank you. I thank you so much because everything you have said.
Both of you are the pillars of the
everything
See,
you have
both
said.
two pillars on
Yeah.
which the whole edifice of gynecology and obstetrics is rested. Both the
No,
pillars are important. The hands are important, and the brain and the brawn both together create the whatever is good in the world. So it's very important to understand that.
so, I'm
Perfectly
Indian at
said.
heart, and basically what pains me is what exactly you said, that fantastic surgeon, fantastic numbers, fantastic research, but nothing gets published and nobody gets creditability. So being an Indian, that is
And
really
in
painful
nature,
to me.
we Indian and Indians are same. We are both are bhai, brother.
So, you have said everything what I wanted to say. And Deepa, unless you have any real questions, can we go?
Yeah, it's been a wonderful session. I think we can go on and on.
Yeah.
Like Vidya said, when Dr. Osama was saying, like, we thought this is the best, then Dr. Rishikesh Pai made it equally good, and you made it equally good. A good note at the end, we had about 650 people logged in on this platform, and 692 logged in on Facebook Live. That's about 1,300 to 400, which is a very good number. All credit to the great faculty that we have today. We have a lot of congratulatory messages. Messages are in fact pouring down, appreciating Dr. Osama's surgeries, appreciating Dr. Jyotsna's presentation, and of course, Dr. Rishikesh Pai. Do we have time for any questions, or can we call it a day? One or two questions addressed to Dr. Osama. In hysteroscopy, morcellation, is it good or bad? We have Dr. Hina Popat from Rajkot. I think we can take a few questions.
The story of the morcellator started initially to treat polyps, not for myoma. This is the start of the idea of the shaver, only for polyps. And then they developed it to remove myoma, but still for small size myoma, and it should be type 0. You cannot do morcellation for myoma with the deep intramural part, because the shaver cannot go deep. And the price of the equipment is very high. And the other alternative technique is much more affordable, which is the resectoscope. So in my opinion, trying to remove a small polyp or a small myoma by a shaver is like trying to kill a mosquito by a machine gun, okay? So I think until they're able to make an affordable price morcellator, which can remove a bigger myoma, but up till now, I'm not convinced.
I agree.
Yeah, and what about the time interval between, if you're doing a 2-stage procedure, what about the time interval? I don't think Dr. Osama will ever do a 2-stage procedure, but still, for the learners.
It can happen anytime, but I mean, you have to give enough time for regeneration of the endometrium damaged around the myoma. I usually them after 2 times. Some surprise happen. Surprise. Sometimes I know that there is a deep part of the myoma left, and I tell the patient after 2 months, and then I don't find it. It's clear. So either the thermal spread burn it, or it's sloughed down. Sometimes.
Whenever I used to do the surgery, now I don't do. I just do embryo transfers. I have left everything, but I used to always keep a watch on the input minus output. As soon as it exceeded 900 ml, I used to stop the surgery. So you have to, and you know what I learned, one of my juniors, so he used to do the resection, Rajesh Modi, he resects it, and then he takes the chunk out, he stops the fluid. So he goes in, resects, stops the fluid, comes out. So the fluid intake was nearly zero. His technique, which I saw once, I was saying, it was very good, because he used to start the flushing, go in, take a big chunk, stop it, take it out. So he was the fluid, because glycine, nowadays, of course, we use a bipolar cautery, and you can use a saline. So we are not that worried. If there's an overload, you can give Lasix and flush it out. But with glycine, you could not tackle the overload with Lasix, because so that was, that's a point. Of course, you are the great surgeon. I don't operate nowadays.
I have good news for you, Rishikesh. Good news that the new development, I have already my own pump designed by myself. The new one has a specification. It measures the inflow and the outflow. If you reach 500 ml, it gives you an orange color. If it reach 900, it gives you red. More than a liter, automatic shut off. It will not continue. So it is obligatory that you have to stop surgery.
Another question to Dr. Rishikesh. How far oral, what size oral medication works? Probably she means ulipristal.
So
Any
the
size
oral
consideration?
medication is a fantastic medication, but you know, I realized that what I was treating was wrong. So you can give it 4 times in 4 batches. So 3 months, 5 milligram daily, then 2 months stop, then again 3 months, like that you can give. And if you look at the side effects, 900,000 cycles have been done. Only 4 liver transplants have been done. I mean, of course, you'll say, what are you saying? But the paracetamol side effect, what the paracetamol also causes liver failure, and you can have liver transplant with crocin, and it is higher than what has happened with this. Problem is that in those 4 and 5 patients, they have not been able to connect the dosage and exactly what was it, whether the dose exposure or the time exposure, they have not. That's why they are investigating whether it is. So because when the first 4 failures occurred, they had a committee meeting in 2018, and they said that, okay, let us monitor the liver enzymes. As soon as liver enzymes are high, we'll stop it. But again, another failure and liver transplant occurred between 2018 and 20. So now we most probably will go to the elagolix will be the right one, which will come. Only thing, we'll have to give a add-back therapy. But as I told you, 2-3 months are enough for us. If we can give in 2 months, the demineralization is not going to take place much. So in 2-3 months, if the elagolix can bring about a decrease in the fibroid volume, it can be a major breakthrough, and a lot of people will get spontaneously pregnant, especially in the range of 3 to 5 centimeters. You give it, there'll be spontaneous pregnancies also. So it is ultimately, I think that it is, my personal opinion, some medicine is going to come and fibroids are going to be knocked out. That's either now or in 10 years time. You forget it. Your surgeries are all going to. It's all. We are going toward nanotechnology now. We are going to have different biotechnology. We are going to have cellular technologies which are going to replace all these things. And gross surgical techniques are going to be there, but they are going to be slowly going down. You know. For example, in cancer, you can give nanobeads, you can inject them, they go and attach to the cancer cells, and then you can put some rays and destroy the cancer cells. Similarly, you may have
targeted.
That may go high, and there may be targeted intervention that may be coming in. So, you know, one day we are all going to have, I keep on telling my son, go into biotechnology, go into deeper, go into cellular technology. Today, what is the power? The power is in cellular, not in gross. Gross is gone. There's no future for the gross.
Just another question. How fast do we expect the fibroids to grow after stopping medical treatment, Dr. Charmila? And how many months should medical management be tried before shifting to a surgical treatment?
3 to 6 months is what Cohen has advised. Dones has advised. 3 to 6 months you can give medical treatment. There's a beautiful chart, which is a structured chart, which he has given in this latest. His latest is a beautiful in 2020 RBM line, beautiful article has come. So 3 to 6 months. So if you have a 3 to 5 centimeter fibroid, you can give ulipristal for 3 months, then 2 months gap, then again a repeat. By the time in 3 months, you stop for 2 months because the changes in the endometrium are abnormal. And there was a worry that whether they are cancerous kind changes, but these are reversible changes. And in 2 months time, the changes become normal. And that is the time when there are already 153 spontaneous pregnancies that have occurred following ulipristal usage in patients with fibroids. Spontaneous pregnancies are 153. So it's a good problem we have to solve is the liver transplant. I was talking to Rishma in the afternoon. I said, Rishma, is it 5 cases in 900,000? What do you think whether we should give or not? I don't know what is the guidance in India, whether the farmers are having this guidance or not. But in Europe, it is. Jyotsna, what is the guidance in United Kingdom? Is it stopped?
We have stopped. We are advised to stop.
Okay.
Yeah. Because particularly the 5th case, they monitored the liver function and they could not see any change. And suddenly she had liver failure. So
right.
MHRA has sent letters to stop it completely.
Yeah, right. So the guidance, but the elagolix or the relugolix, which is the other one which has shown a 50% reduction in fibroid mass. So these are, you can do IVF now. Your cetrotide is going to go away. You just give daily one tablet and there will be no LH surge. So that's of course an off-label use. But all these, the new breakthrough of oral antagonists is a major breakthrough in gynecology.
So after stopping ulipristal, when do you start IVF?
2 months later. 2 months later.
2 months.
Because it takes the reversal changes. There are endometrial changes called PACE, I forget it. It's called PACES. So that these reversal takes 2 months. So from the second cycle, you should start attempting pregnancy. But I was giving it for 2 months and I said, this is not affecting the size of because it takes 3 to 4 intervals of ulipristal for actual slowly reduction of the size.
Yeah, that's another problem. Even with myomectomy, patient has to wait. Right. And even with medical treatment, patient has to wait. So that wait of 3 to 6 months in a 38 or 39-year-old, whichever one you want to choose, gets quite tricky.
Right. So what I do, Jyotsna, I do the IVF. So nowadays, for all pathologies, adenomyosis, for endometriosis, everything, we do the IVF. We pool the embryos. We collect about 5 to 10 embryos, and then we do the tackling of the pathology. So it's become a habit only. So we will do first the retrieval, we'll freeze the embryos, then we tackle the pathology, and then we transfer the embryos. So and then because she's at 37, which she still has enough ovarian reserve, so we can collect embryos. By the time we do the second cycle, she'll be 39. So this is the best way to collect the embryos beforehand.
So that's a perfect strategy.
1 minute. A question from Dr. Apeksha Hyderabad to Dr. Osama. What are the tips and tricks you will advise while dilating the cervix to prevent leakage?
Well, as I always mention, the most important key for success of any intrauterine surgery is to keep the cavity distended.
Yeah, distended.
So sometimes the cervix, if you see my hand, sometimes the external os or the cervical canal is wide or whatever, and there is a lot of leakage around. So what I advise, and then I will confess a secret after that, because this trick is not my invention. I'll tell you who taught me. So when the hysteroscope like this and leakage from the side, you bring a tenaculum, single tooth tenaculum, and you catch at 9 o'clock or 3 o'clock, and you grab it to tighten the external os over the sheet, okay? Just by tenaculum here. I learned this tip from a very, very humble, maybe not educated worker in a small hospital in a city called Ranchi, okay? She told me I was doing a difficult surgery and I have a lot of leakage and the pressure of fluid was not enough. And the humble lady said, sir, can we tighten this by putting an instrument here? And I learned from her. I don't know her name, but I'm telling the story to tell you can learn at each and every place from the most humble person. And since then, I can close the cervix and get a very good distension inside.
Yeah, thank you, sir. Questions, Deepa? Any more?
I think we are good to go.
So many congratulatory messages.
Yeah, most questions answered, many unanswered.
My office starts after 15 minutes. You will go to sleep and I go to work.
One more question, please, from Dr. Victoria Johnson from Trichy. Post-hysteroscopic medical treatment before fertility treatment. Anything is there, sir? Dr. Osama?
There is already a published multi-center study about the value of post-operative treatment after septum, whether we put a balloon or a IUD or estrogen, progesterone or nothing. The best healing was after doing nothing at all. You don't have to give any medical treatment, hormones or whatever. You only need to put a barrier inside the cavity only after Asherman. But after myomectomy, no need. No need.
Okay.
And one more thing I want to finish before I go, important advice about bleeding during hysteroscopic surgery or hysteroscopic myomectomy. Sometimes when you do resection, you are surprised by a pumping angry vessels, bleeders, okay? For the beginners, they get panicked and they insist to follow and cauterize, like I showed you in one of my videos. In fact, and trust me, you don't need to cauterize and leave them. You don't need to cauterize at all, although they look scary and pumping. Just when you go out and the cavity collapse, observe for 2 minutes, stop. The same like after delivery of the placenta and the uterus contract. So long there is normal blood pressure and good coagulation profile, any bleeder will stop in hysteroscopy, because the blood vessels coming from the endometrial side, they are the arcuate and radial arteries going through the myometrium. So when the myometrium contract, they stop. No worry at all from bleeding.
So I want to make a point that if there is a patient who has had intensive surgery, either laparoscopically or hysteroscopically, I always do a second look hysteroscopy prior to the transfer, because many times these surgeons are there to put a stitch and it goes to the uterine cavity. They are not aware of it, or there can be, Dr. Osama may remove 4 or 5 fibroids and there may be addition. So I always look, because I am an algorithm person. I will always do the scopy. Then I will do the transfer of the embryo, because that is where I will catch. And I can show you many videos. I do it, my assistant do it. I don't do anymore. But when beautiful, you'll have nice vertical adhesions which you cut. The stitch has gone through the uterine cavity.
We can call it a day. I think it's time to wrap up. It's been a fantastic session. No words to thank all my faculty. Words defy my gratitude. It's been a great, great session. I think we are blessed. Trichy Society, this will be a landmark day in our academic this thing. So thank you so much to everyone, Dr. Rishikesh, Dr. Jyotsna, Dr. Osama, for spending so much of your valuable time with us today. And to all the viewers here, I'm sure you all enjoyed the experience of surgery versus medicine and the debate as well. There are answered questions, there are unanswered questions. I think the CME goes on. We'll invite a few months ahead or a few years ahead. We'll get back to find more answers. I think that's the bottom line.
And Osama will give us the answers in the future. Thank you.
As you said, sir, it's only nanotechnology and cellular medicine hereafter.
Just, I miss you very much, Rishikesh, and I miss Nandita and everybody, Rohan, everybody in Mumbai. I miss you very much. All India, God bless.
Bye.
Thank you so much.
Thank you so much, sir. Thank you, Jyotsna.
Yeah.
Thank you, Dr.
To
Osama.
everyone.
Thank you, Dr.
To Lupin, it's been a great
Lupin.
Thank you, Ashish Singh and Saurabh.